So hello, my name is Neil Spenceley. I'm the Paediatric Patient Safety Lead. I'm also an intensivist in Glasgow. So this is a short presentation really looking at PEWS, so Paediatric Early Warning Score, why we need a PEWS, where it's come from, and our thoughts behind why we need a national one. So picking up the deteriorating patient has been a problem forever really. And interestingly, early warning scores were only really thought of about, maybe 15, 20 years ago in the adult population, when it was realised that patients were dying on hospital wards really with potential warning signs that had been present for 24 hours beforehand. So they developed a sort of trigger system, which then developed into an early warning score to really help alert people to deteriorating patients early. And as we all know, if we pick these guys up earlier, then there's going to be less likely to be mortality and morbidity in this population. So it's well recognised that picking up the deteriorating child is a good deal trickier. And in this paper from 2011 by Gail Pearson, Why Children Die, they recognise that possibly the most significant recurrent and avoidable factor with these cases that had gone on to morbidity or mortality, had been missed, had deteriorated to a severe degree, was actually the failure to recognise severe illness in children. And so the recognition of the sick and deteriorating child became a great focus in the paediatric work strand of McQuick. And our sort of thoughts were, well, why don't we think about introducing a national PEWS which can not only standardise how we pick these children up, it can create a common language, it can perhaps improve communication, and it can perhaps be used as sort of a cultural tool in order to flatten hierarchies and allow people at the front line to raise their hand when they're concerned and be listened to. Subsequent to that paper, in 2014, Ingrid Wolf did this report in collaboration with the RCPCH, Why Children Die, and it's challenging reading. It's a very good document, but it's a disturbing document, and it's disturbing because whilst all European countries, which is what it looked at, have made significant improvements in reducing the morbidity and mortality in children, really across the board. As you can see by the black line here, in the UK, that improvement has been less vigorous and less successful than other countries. And in fact, the real reality is that if we compare UK mortality with the best in class, there is an excess of, believe it or not, 1,900 to 2,000 deaths in the UK per year. So that's an excess of 5 deaths in the UK compared to the best in class within in Europe. And the highest rates were in infancy and in adolescence. And if you read further into the texts, they realised that many of these deaths were potentially avoidable, and perhaps up to about 43% of deaths, which is something that we would really like to focus on, because this is something that we as a team in Scotland can perhaps improve upon. There were sort of challenges to this, because people were saying, well, do you know, you're comparing us against many different healthcares in Europe, many different patient demographics, many different funding streams, capabilities. So surely, if you look at us compared to a myriad of different healthcare systems, there's going to be differences. What if you compared us just to one healthcare system that was similar? So a team, in fact, did that. So they compared the UK directly with Sweden. Now Sweden has got a smaller population, but in fact they say they spend the same amount, the same percentage of their GDP in healthcare. They've got the same technology, the bells and whistles, the levels of intensive care, high dependency, etc. And they've got the same antibiotics. So they thought, well, that will iron out some wrinkles and we'll probably be broadly similar. And of course we weren't. So it showed that children under 5 are twice as likely to die in the UK than in Sweden. So this is troubling. And if you go on to look at the paper, it has two sort of nice boxes in it. So what's already known? Well, the UK has a high mortality rate compared to Sweden. Prematurity is the major cause of death in children less than 5 years, and that's in both countries, but it's more prevalent in the UK. And the socioeconomic inequalities, which of course we're all too aware here in Scotland, contribute to child mortality and prematurity. What the study added, however, was that the mortality rates for infections in particular of children aged less than 5 are significantly higher in the UK than in Sweden, and that the majority of these infections were treatable. As I said, the Swedish had no different bacteria, no different levels of intensive care, no magical antibiotics. So there's something that we were doing differently. So they recommended actually that rather than researching on new medicines, perhaps there was a service delivery and access or system problem that needed to be addressed. So has anybody already designed a system which can pick up the deteriorating child a bit quicker? And if so, what do they do? And if so, did they write it down? And of course they have. And so Pat Brady and his team from Cincinnati Children's wrote this paper in 2012, which is really improving situational awareness to reduce unrecognized clinical deterioration. Now, Pat gave a fantastic WebEx to us at the end of April. And if you click on the link in the blue, then it can take you to that. And it's about 35 minutes, and there's some questions and answers at the very end. So he uses this great quote, which I am very fond of and have hijacked and use myself now. So patients don't suddenly deteriorate, healthcare staff suddenly notice. And why is it that we just suddenly notice? Well, it's likely, particularly in paediatrics, that the child has got to such a stage of acuity or unwellness that they suddenly become apparent to us. But what they recognised was that the children didn't suddenly deteriorate. They had been deteriorating over a period of time. And they realised that looking at various critical incidents within their own hospital and admissions to intensive care, that if a child was intubated, ventilated, had 3 fluid boluses or started on inotropes, or usually all 3, within an hour of intensive care or appropriate expertise coming to the bedside, then it was likely that the deterioration hadn't just happened within that hour. It's likely that the deterioration had been a little bit more sneaky and occult for the previous couple of hours, 6 hours, 12 hours, 24 hours. So they looked at a number of commonalities in these cases, and there were certainly things that were recurrent. And for the purposes of this discussion, then there were 3 things which were very evident in most of these children that were admitted to intensive care. So there was, there was family concern, but that's something which you can't really write down. Many of these patients were deemed watchers. So watcher is just basically, is there something about this child that you don't think is right? It's a kind of a gut feeling, a sixth sense, which is very evident, particularly with skilled and trained people who deal with children, A, the parents, and B, the healthcare workers. And this is something that, that causes just a general anxiety. And of course there was elevated PEWS, so elevated paediatric early warning scores. And they realized if they concentrated on these and others, such as high-risk therapies and communication concerns, then these should highlight these children as potential for deterioration, or are in fact are deteriorating. So it's to improve a thing called situational awareness. And we're hearing this term a lot now, although many of us haven't really been on situational awareness courses. Perhaps the best definition of it comes from Rona Flynn. So she's an industrial psychologist in Aberdeen, and she's wrote this great book, Safety at the Sharp End, which is pretty hard going, but it's well worth looking at. And she recognised that as the hardware and the software, so the computers, the technology, the machinery, the lab results, all sorts of things that are involve technology, that as they're becoming more reliable, they reckon that the contribution that is human, their contribution to accidents has become ever more apparent. It's not that we're actually becoming more accident prone as humans, it's just that it's becoming more obvious as other parts of the system are seemed to be safer. So why not improve our safety, and why not improve our ability to pick up these children or pick up any sort of events by improving our situational awareness? And she describes situational awareness as the what, the so what, and the now what. So the what is happening at the moment. So perhaps you have a child who is breathless, who's in front of you. The so what is, well, what do you understand by what's happening? And it might be that this child has got an exacerbation of asthma, is needing to be multidosed, have some steroids, is on oxygen. And then now what? Well, that's the kind of prediction. What do you think could potentially happen in the next 10 minutes, the next hour, the next day? And if you think that these things are going to happen, then what are you going to do about it? And so it might be that this child deteriorates, needs more oxygen, might need intravenous bronchodilators, might need some non-invasive respiratory support, might need invasive respiratory support. And it's all very well picking that up at the time and activating the sort of increased in medications or bringing expertise to the bedside. But actually the clever money is doing this beforehand. Bringing expertise to the bedside and having a chat and a discussion about if this child deteriorates, it may well look like this, and in which case, what are we going to do about it, and who else do we need to be here to help us with that? And in fact, that's what Pat found in his paper, that improving the situational awareness was all very well, either by being a watcher or a parental concern, or if your PEWS are going up. And if you bring expertise to the bedside, that's great, but quite often expertise will just agree with what you found. The real money shot was actually having an escalation plan, and having that plan together with the stakeholders, so nursing, medical staff, senior medical staff within the ward, medical staff out with the ward, sometimes medical staff out with the institution. This is what we think is happening, this is what we think might happen, and this is the plan that we should have. This is the escalation plan that we're going to implement if such and such happens. This is who is going to do it, and this is the time scale within which we want to achieve it. So the idea of situational awareness came from American aircraft carrier groups, and it is a group. It's not just an aircraft carrier. It's surrounded by a whole load of ships and submarines in order to protect it. And they realised that they needed to know precisely what was going on at all times, not just on the aircraft carrier itself, but within the entire group. So they had 8 hourly huddles, for want of a better description, where they would look back at the previous 24 hours, what was their understanding of what had happened during the previous day, what is happening right now, what do they understand about what's happening right now, and what do they think might happen in the future. And actually, Steve Muthane's, one of Pat Brady's consultant colleagues, went and spent a couple of weeks with them to learn about how to improve the situational awareness. And one of the things that they had to do was streamline communication and make sure that that communication was effective, and make sure that that communication could be escalated to the correct people at the correct time. So for that, then they developed SBAR, which is situation, background, assessment, and recommendation. So what do I think is going on at the moment? Do I think could happen in the future? So it is also, it's really like, how do I describe and articulate the situational awareness, and how do I make sure that the people that I need to know are aware of my concerns, are appropriately informed. Now, there's actually a very good video on the Risky Business website by what's termed a naval aviator, but he's an American who's he's just fundamentally a pilot. But he talks about the idea of situational awareness and SBAR communication and escalating your concerns in a sort of a non-hierarchical, efficient manner, and in a manner that uses SBAR to communicate your concerns from the front line in a very sort of timely and efficient way. Situational awareness is becoming very evident in paediatrics, and Peter Lachman is looking at a thing called SAFE, which is situational awareness for everyone, and this is really a protocol to try and evaluate how best to improve situational awareness within the paediatric community. And as you can see by this table here in the mitigation section, then PEWS is one of the tools that is used to identify children who are deteriorating or who are unwell, and used then as a starting point to escalate to the correct level of expertise. At that point, they would perhaps do that using SBAR. They would bring expertise to the bedside, where there would be a huddle. There would be a discussion about what their understanding was of this child's current condition and how they were going to improve it, or if they did deteriorate further, what the escalation plan would be. So what can PEWS do? Well, the score on its own does nothing. The score can't ask for help. The chart itself can't ask for help. But if there is the correct culture and the correct environment, then the score can alert staff at the bedside to escalate their concerns in a timely manner, so that they have recognised the sick child, or they have recognised that this child could potentially become sick. And that has shown to reduce crash call rates, reduce morbidity and mortality. And if used reliably, it can alter the frequency of observations, as I said, bring expertise to the bedside, and allow a plan of action to be formulated and undertaken within a certain timescale. But perhaps the most important aspect of escalation is the level of comfort and ease of communication between team members. Ultimately, it's the cultural element that enhances the safety. And we think that then maybe the introduction of a national PEWS should prompt a discussion about how every team member or every parent, every cleaner, every consultant could raise their hands if they're worried about an objective measure or subjective feeling. And it really is that the score in itself is never a replacement for clinical judgment. And if there is that sort of concern, even if the monitoring doesn't say that there's a problem, the PEWS doesn't say that there's a problem. If people by the bedside think that there is a problem, then they should ask for support, even if the score is low. And that's why there's a section in the chart saying, look, even if the PEWS chart is normal, all the lines are going in the right direction or staying the same, but you think that there's something wrong with this child, then you have permission to escalate and permission to override the PEWS chart, the PEWS score, whatever it might be. And I think I'll leave you with this excellent paper from Ulf Thailand's group in Edinburgh, who looked at in situ simulation training on the wards, and how over a number of years that really improved the pickup of these patients who are deteriorating or unwell, and actually reduced the number of ICU admissions, or in fact their length of stay. And for me, this is the most pertinent paragraph, that with time people were comfortable to raise their hands if they were concerned about some sort of subjective element of the child, rather than having an objective score that had breached some physiological criteria. And to me, that is sort of the essence of what this National PEWS and how we're hopefully going to collaborate to make this work is all about. It's about having a chat and discussing how we're going to escalate these children appropriately, that everybody can escalate the children if they are concerned, even if it's just a gut feeling, rather than actually having a score that is too high. And that really sort of is shifting the culture and the culture of the organisation, and allowing people at the front line to do their job better and to do it well, giving them the time and the comfort and the ease to escalate these children if they're concerned. Well, I hope that was of some use. I'm sorry there's a plane went over my house, so it might have been a bit noisy. If you can name the model and power output, answers on a postcard, and I'll give you a chocolate frog. If you wish to answer any questions, then you can either ask myself, or if you want a more useful answer, then you can ask Leslie. But please feel free to get in contact. We'll come around and see you all as well, and we'll be very keen to hear your ideas about how we can contribute to this National PEWS endeavour. Thanks very much.